Good afternoon. It's a pleasure for me to be here this year to review a very pertinent topic in the clinic, not only today, but also in the future. I would like to, of course, thank Sanofi Aventis for allowing me to be part of this esteemed faculty. So today, as I discuss individualized approaches to patients with breast cancer, I want to talk a little bit about the state of the art. I will talk a little bit about the challenges that we encounter, and then come up with some potential recommendations for solutions to this problem. When we think about personalized medicine, we really want the patients, the specific right patient, to get the right drug and also to receive the appropriate doses of the drugs at hand. So to be more specific, we may have a group of patients with the same diagnosis who receive the same type of recommendation for therapy, when some of these patients may experience toxicity from the drug and the drug may help. Other patients may develop toxicity from the drugs but without any benefit. On the other hand, there are patients who may experience no toxicity from the drug, still the drug doesn't help. And in other groups of patients, the drug is not toxic and the drug is beneficial, which is obviously the group that we want to expand in the next few years. So what are the goals of individualized or personalized treatment for patients with cancer and specifically breast cancer? Well, we need available prognostic tools to identify patients who need treatment. We want to be able to identify only those patients who will benefit from particular therapy. We want to identify the type of patient or the patient who will need different doses compared to other patients. And certainly, we want to be able to identify patients for whom we would not recommend a therapy as they would not be expected to benefit from the treatment, which is part of the discussion. But we can be even more specific than that. And so let's go over the different scenarios. As I see that treatment individualization will allow us to diagnose the subtype of breast cancer more precisely so that then we can recommend more effective treatments. We'll be able to select specific treatment that best fits the disease and target the medication for that disease, certainly avoid adverse drug reactions, and avoid delay from false starts. In other words, if we can identify the patient who will benefit or not benefit from one therapy, then we can make the right decision right at the beginning of treatment instead of the empirical approach that we have had to use over the last few years. In the setting of early breast cancer, we want to predict risk before symptoms occur, and that also applies in the setting of metastatic disease, because those patients also deserve the opportunity from having preventive medications for any symptoms that may occur secondary to the treatments administered. Certainly, we want to eliminate unnecessary treatment, provide better timing for introduction of any medications, and adjust treatments as quickly as possible depending on the likelihood of response. We can now think about the specific subcategories which we will utilize this individualized approach. Certainly, we can use individualized approach to make the selection of drugs, for the doses of the drug, to determine whether the drugs will be efficacious. We would like to have some other markers that will be able to help us assess the disease status, because in 2010, we're still not perfect at that. Think of this scenario: patients who have early-stage breast cancer, all of this is removed by surgery, the patients receive radiation therapy, and there's still a subset of patients who have either node-negative or node-positive breast cancer who are the ones who are going to develop metastatic disease. So we need to be able to identify the specific stage of disease, especially for those patients who do not have any readily visible tumor by the currently available pathological or radiologic techniques. Certainly, we need individualized medicine to help us better characterize patients who are predisposed to develop breast cancer. And this scenario is also particularly important in the setting of screening, because if we could have better predictors of patients in the general population, even those without BRCA1 or BRCA2 mutations, who are more likely than others to develop breast cancer, then we'll be able to better utilize general screening techniques such as a mammography. Tell you, this sounds beautiful in terms of the simplicity of the concepts. However, this is not as straightforward as once thought, as exemplified by this cartoon and certainly by the elegant presentation by Dr. Yarden just a few minutes ago. So where we are today related to the ability to predict for benefit to the therapies that are currently available? Well, if we think about anthracyclines and taxanes, as you see on this slide, I have little dots, I have question marks. And the reason for that is that we don't have any definite treatment that any of these markers are really predictive for benefit of these commonly utilized agents. If we think of the setting of anti-estrogen therapy, really a pretty similar situation occurs. But at least in the setting of hormone receptor positivity, we understand one thing, and it is that if the patient's tumors are estrogen and or progesterone receptor negative, that is a pretty good predictor of lack of response to hormonal manipulations. However, we're far from perfect, as even when tumors express these receptors, if patients receive currently available anti-estrogen therapy, certainly in the metastatic setting, only 30 to 40% of these patients really achieve measurable reduction of tumor size by the introduction of tamoxifen or aromatase inhibitors, as demonstrated by many clinical trials. So certainly, more work is needed to optimize therapy for even these patients with hormone-responsive breast cancer, quote unquote, and that's why combinations of anti-estrogens with targeted therapies remain a very important area for research. As you see in that asterisk that went by very quickly, the same situation applies for anti-HER2 therapy. Certainly, there are many issues related to anti-HER2 therapy, including reliability of HER2 testing, either by immunohistochemistry or fluorescence in situ hybridization. But even for patients who are determined to have, maybe we can go one slide back, even for patients who are deemed to have tumors that express or overexpress the HER2 protein or amplify the HER2 gene, the benefit to single agent anti-HER2 therapy in the form of either trastuzumab or lapatinib is really only in the range of about 25%. So combination strategies can be most beneficial even in those settings. So as we move forward, we really need to introduce the concept of genetics within this particular talk. On the left, we have the approaches that we have utilized before this genomic era, in which we utilized traditional measures of recurrence risk to make determinations related to which patients needed therapy, and also to be able to explain to the patients in very general terms the prognosis after a diagnosis of breast cancer. So we utilized tumor size, tumor grade, disease stage, age in some situations, because that may impact therapy. We certainly took a tumor biopsy for appropriate testing, but before the introduction of this genomic area, we really didn't have, as you well know, the test that we have needed to predict true effects or tolerability from a treatment. However, we're really moving into this genomic era with the idea that expression of certain proteins and genes really are helpful for the prediction of benefit of agents. We're starting to utilize gene expression profiling to evaluate prognosis and benefit to some of these agents. And we're only starting to utilize genomic techniques in the area of pharmacogenetics to also determine whether there are differences amongst individuals related to the metabolisms of drugs which may affect benefit or lack thereof. So now we're moving into the new tailored clinical trials to develop tailored interventions or to better tailor existing treatment modalities. Because, we are thinking a lot about the development of new agents, but we also need to devote some efforts to optimize the utilization of the agents that we already have an idea of them working in the setting of breast cancer. We have talked about hormone responsiveness, we have talked about HER2 positivity, and now we are talking more and more about targeted treatment for patients with triple-negative breast cancer, which in the past has been the type of breast cancer that has been left almost alone in terms of having targeted treatments. We really need to work together to have extensional translational research programs. Many people talk about what is really translational research, and they talk about information from basic research laboratories to move into the clinic. But some people have started to think about this in a different way, that we should really start with the patient, observing the patients, evaluating how different patients respond from our therapies, follow the patients, and then take that information into the laboratory to be able to understand the clinical scenarios of patients and then come up with novel approaches that would ultimately go back to the clinic. Certainly, this approach requires wide international collaboration and a lot of resources. You've heard some today, and certainly in the literature, quite a bit over the last few years, related to the introduction of a molecular or intrinsic subtyping in the setting of breast cancer, utilizing microarray identified gene expression profiles, which have subdivided breast cancer in the different subgroups that I listed on this particular slide. But I tell you, gene profiling utilizing microarrays is really not the end game that, quote unquote, that we're looking for. And as alluded to earlier today, we're really looking at profiling that goes beyond microarrays, looking at transcriptional profiling, epigenetic changes such as methylation, microRNA, that may really impact the understanding of patient outcome. And we're looking not only at single markers, but also examining pathways in the context of their relevance on the pathophysiology of breast cancer. But what are the hurdles to individualized care? And I have a couple of slides on this issue. Well, we still have an incomplete understanding of the biology and tumor microenvironment. We do not yet know the optimal predictors of metastasis, and we still need to identify whether there are specific markers in the tumor or the stroma that could help us identify the potential sites of metastatic disease so that better targeted approaches can be developed. Another area that prevents true individualized care today is that many of the trials that have been performed today really rely on biological evaluations of primary tumors, but there are very few studies that are being done in the context of evaluation of the biology of metastatic disease. And this is something I think that we all need to try to solve together, because there might be differences in even the commonly known markers, ER, PR, HER2, from the primary to the metastatic setting. And this obviously is going to be much more complex as we identify other potential targets for patient treatment. Additionally, there's also reluctance to adopt new strategies. Certainly, this does not happen to a group like you, because you are here trying to have a discussion with all of us related to the new information, so that the new information can be applied to practice. But one of our roles is really to get this information and help others understand the value of the new data in terms of patient management on a day-to-day basis. Sometimes people are reluctant to adopt new strategies based on various factors. It may be that there's an understanding that even though there may be various manuscripts saying that we should use this molecular marker versus another, in some of these cases, the number of patients is rather small, so we think, well, the data are not robust enough, so I'm not going to change my usual practice. Additionally, although not in this slide, sometimes we are reluctant to adopt new strategies because of reimbursement issues that prevent us from utilizing the newer approaches for our patients. However, things are evolving, because there's a greater acceptance that we need to move beyond the old and think of the new so that survival for breast cancer can be improved. Certainly for payers, this will be a great thing, because if we have more precise treatments for our patients, then insurance companies and governments will be able to best utilize their financial resources. Certainly for all of us as physicians, we want to avoid utilizing ineffective therapies. Of course, this is a tremendous win for our patients. For pharmaceutical industry, this also applies. And it's very important, although sometimes not discussed at length, is that both our colleagues in pathology, radiology, really are working with all of us so that we can have appropriate collection of tumor specimens, documenting what happens after the tumors are removed from patients, so that we can have consistent techniques for evaluation of the different markers for patient therapy. So it all goes back to a patient-centric approach with the help of many other persons to be able to individualize that treatment. In summary, as was alluded to earlier, one-size-fits-all approach is over in the setting of breast cancer. Understanding the molecular basis of cancer has already allowed us to identify some of the disease biomarkers to appropriately select patients for various treatments. Some of this understanding has led to elucidation of novel targets. So we have a proof of concept, but we still need to improve on this characterization. As a last slide, I envision that in the future we will have many different types of breast cancer based on the molecular basis of this disease. Thank you very much.